Four patients arrive at once: chest pain, compound fracture, febrile child, slurred speech. How do you triage them?
I would use the ABCD approach and treat this as two immediate life threats and two urgent cases. The slurred speech points to a possible stroke, so that patient needs a rapid neuro check and a call for a stroke alert, since time lost is brain lost. The chest pain patient also needs eyes on them fast and ECG within minutes, because it could be a cardiac event. I would ask a colleague to apply a tourniquet or pressure dressing and check circulation on the compound fracture while I assess the two time-critical patients myself. The febrile child, while distressing for the parents, is usually the most stable of the four unless there are signs of sepsis, such as lethargy or poor perfusion, so I would delegate a quick set of vitals there. I would keep communicating with the charge nurse the whole time, so resources get pulled in quickly. Once I trust simple checks are done, I return to reassess everyone in order of acuity. In real shifts, I have done exactly this kind of split-second sorting, and the key lesson I carry is that triage is never static. You keep retriaging as new information comes in.
Vital signs were stable, but your clinical intuition told you the patient was deteriorating. What did you do?
I had a post-operative patient whose blood pressure, heart rate, and oxygen saturation were all within normal range, but something felt wrong. She was quieter than usual, her skin looked slightly gray, and she was reluctant to move. I trusted that instinct instead of dismissing it because the numbers looked fine. I did a full head-to-toe reassessment, checked her urine output, which had dropped, and rechecked her abdomen, which was becoming more tender. I escalated to the on-call doctor, explaining clearly what I was seeing rather than just repeating normal vitals, and asked for a review within the hour rather than waiting for the routine round. Blood tests showed her hemoglobin had fallen, and she was taken back to theater for a bleed that wasn't yet visible on the monitor. That experience reinforced for me that vital signs are only one part of the picture. Subtle changes in color, behavior, and patient report matter just as much. Since then, I always document these soft signs explicitly because they give the next clinician the same warning I had, even if the numbers still look normal.
How do you prioritize care in the ER when all rooms are full and patients are waiting in the hallway?
In that situation, I go back to acuity rather than room number. I walk the hallway myself or ask a colleague to, so no one is forgotten just because they are not in a bed yet. I look for red flags: chest pain, breathing difficulty, altered mental state, uncontrolled bleeding, and I move those patients up regardless of how long they have waited. For patients who are stable, I explain honestly that there is a delay and give them a rough idea of what is happening, which reduces frustration more than silence does. I also communicate constantly with the charge nurse about which rooms might free up soon, so we can move the sickest hallway patients in first. Documentation matters here too. I make sure vitals are repeated on hallway patients at safe intervals so decline is caught early. On one particularly full night shift, this approach meant a hallway patient with worsening abdominal pain was moved and treated before their scheduled turn, which likely prevented a ruptured appendix. The main thing I have learned is that a full department does not mean lower standards. It means tighter organization and more frequent rechecking.
Walk through your step-by-step approach when a patient presents with sudden onset severe shortness of breath.
First, I make sure the patient is safe where they are and call for help immediately rather than trying to manage it alone. I sit them upright, since this often eases breathing, and apply oxygen while getting a full set of vital signs, including oxygen saturation and respiratory rate. I look and listen quickly. Are they using accessory muscles? Is there stridor or wheeze? Is one side of the chest moving less? Is there swelling in the legs that might suggest a clot? I ask short, direct questions, or their family if they cannot speak, about onset, past history like asthma or heart failure, and any recent travel or surgery. I get for access, attach a cardiac monitor, and request an urgent ECG and chest X-ray while the doctor is being called. If they deteriorate further, I prepare emergency airway equipment nearby in case escalation is needed. Throughout this, I try to stay calm and speak steadily to the patient, since panic on my part increases their fear and can worsen the breathing. I have run through this sequence many times, And having a consistent order of actions means nothing important gets missed, even when things move fast.
How do you handle a scenario where a physician's triage order conflicts with your clinical assessment?
I raise it directly and promptly rather than quietly following an order I am unsure about. There was a case where a doctor triaged a patient as lower priority, but my assessment showed a rising heart rate and worsening pain that did not fit that category. I approached the doctor privately, described exactly what I was seeing in objective terms, and asked if they wanted to reassess given the new findings. I find it helps to frame it as new information rather than as a disagreement, because it keeps the conversation collaborative instead of confrontational. In this case, the doctor came back, reassessed, and the patient was moved up and treated sooner. If a doctor still disagrees after hearing my concerns and I remain worried, I document my assessment clearly and, if needed, escalate to a senior nurse or the charge nurse, since patient safety comes first. I never simply ignore my own judgment to avoid conflict. Over time, this has built trust with the doctors I work with regularly, because they know I only push back when I have a genuine clinical reason, not out of habit.
How do you manage an agitated patient who is refusing care and trying to leave against medical advice?
I start by lowering my own voice and slowing down, since matching someone's agitation only escalates it further. I try to understand what is driving their wish to leave, whether it is fear, pain, a family issue at home, or feeling unheard, because addressing the real concern often works better than repeating instructions. I once had a man who wanted to leave mid-workup for chest pain because he was worried about his dog alone at home. Once I helped him arrange for a neighbor to check on the dog, he agreed to stay for the rest of his tests. When a patient still wants to leave, I clearly explain the risks of leaving in plain language, not medical jargon, and make sure they understand what could happen. If they are competent to make that decision, I respect it, document the conversation thoroughly, and have them sign the AMA form. I never physically restrain a capable adult who chooses to leave. What I focus on is making sure they leave as informed and as safely as possible, with instructions on when to return, rather than making them feel judged for their decision.
Describe a time you had to de-escalate an aggressive family member in a crowded waiting room.
A patient's brother once became loud and confrontational because his sister had been waiting nearly 3 hours with abdominal pain. Other families in the waiting room were visibly unsettled, so I needed to act quickly but calmly. I walked over, introduced myself, and asked if we could speak just to the side rather than in the middle of the room, which took some of the audience pressure off him. I acknowledged that the wait was genuinely frustrating and did not get defensive, even though the delay was due to more urgent cases ahead of her. I gave him honest information about roughly how much longer it might be and explained that sicker patients were seen first, which he had not understood. I also checked in with his sister again in front of him, which showed action rather than just words. His tone dropped noticeably once he felt heard and saw something being done. I always try to remember that anger in these situations is usually fear about a loved one, not really about me, and treating it that way tends to bring the temperature down faster than arguing back.
How do you handle a patient suspected of drug-seeking behavior while still assessing their pain properly?
I treat the pain assessment the same way I would for any other patient, because suspicion is not the same as certainty, and undertreating genuine pain causes real harm. I ask specific questions about the pain's location, quality, and what makes it better or worse, and I look for objective signs like guarding, sweating, or changes in vital signs that support or don't support what they're reporting. I check the patient's history and any prescription monitoring records available to me, and I loop in the treating doctor with my findings rather than making the call alone. There was a patient who had a long history of opioid requests, but on this visit his presentation was different, with new swelling and fever, and it turned out to be a genuine abscess needing urgent treatment. That case taught me not to let a label from previous visits override a fresh assessment. If drug-seeking behavior is confirmed, I still treat the person with respect and follow the agreed pain management plan or refer them appropriately, rather than dismissing them, since stigma in these situations can push people away from care entirely.
What steps do you take when managing a psychiatric patient expressing active suicidal ideation in an unsecured room?
Safety is the first priority, so I never leave that patient alone. I immediately arrange for one-to-one observation, even if that means pulling a colleague from another task temporarily, and I move the patient to the most secure area available while a proper room is arranged. I quickly remove or ask the patient to hand over any obvious means of harm, such as sharp objects, cords, or medications, doing this calmly and explaining why rather than making it feel punitive. I speak to the patient directly and gently, asking clearly about their plan and intent, since asking does not increase risk and gives me the information needed to judge urgency. I inform the doctor and psychiatric liaison team immediately so a proper risk assessment and secure placement can be arranged. Throughout, I try to stay present and non-judgmental, letting the patient know they are being taken seriously and are not in trouble. I document the conversation, the actions taken, and the times clearly, since this protects both the patient and the team. This kind of situation always reminds me that vigilance and compassion have to work together.
How do you maintain composure and professional boundaries when a patient becomes verbally abusive toward you?
I remind myself in the moment that the behavior usually comes from fear, pain, or feeling out of control, not truly from something personal about me. I keep my voice steady and my body language open rather than defensive, and I avoid raising my own tone even if the patient raises theirs. I once had a patient shout and swear at me after a long wait for pain relief that was delayed due to a physician review. Instead of reacting, I acknowledged his frustration, explained honestly why there was a delay, and told him I was actively chasing it up, which I then did straight away. His tone softened once he felt something was being done rather than ignored. That said, I do have limits. If language becomes threatening or unsafe, I calmly state that I will step away and get a colleague or security involved, because tolerating abuse does not help either of us. Afterward, I always report incidents through the correct channel rather than brushing them off, both for my own well-being and so patterns of behavior are recorded. Staying composed does not mean staying silent about what is acceptable.
Walk me through your immediate actions when a patient unexpectedly goes into cardiac arrest in a standard treatment room.
The first thing I do is confirm unresponsiveness and absence of normal breathing, then call for help immediately and start the emergency alert. I begin chest compressions right away rather than waiting for equipment, since early compressions matter more than anything else in the first minute. As help arrives, I ask one colleague to bring the crash cart and defibrillator while I continue compressions, and I assign roles clearly rather than assuming everyone knows what to do. Once the defibrillator arrives, I apply the pads quickly and follow the rhythm analysis and shock advice exactly as instructed. I make sure someone is managing the airway and someone is preparing for or IO access for medications. I keep track of time for compression cycles and adrenaline doses, calling them out loud so the team stays coordinated. Throughout, I try to keep communication short and specific, using names and clear instructions rather than general shouting. Once the resuscitation team leader arrives, I hand over what has been done so far concisely. I have been part of several of these situations, and I have learned that calm, clear communication saves as many lives as the compressions themselves.
Describe your role and responsibilities during a massive transfusion protocol for a severe trauma patient.
In a massive transfusion situation, my role is usually to manage access, administration, and monitoring, while others focus on the injury itself. I make sure at least 2 large-bore 4 lines are secured early, since transfusion speed depends on good access. I coordinate closely with the blood bank, confirming patient identification carefully even under time pressure, because errors here are extremely dangerous. As units of blood, plasma, and platelets arrive, I check them against the protocol ratio being followed and administer them promptly, using a blood warmer where needed to prevent hypothermia. I monitor vital signs continuously, watching for signs of transfusion reaction or worsening shock, and I track how many units have gone in so the team has an accurate running total. I also keep documentation tight, since these cases are reviewed afterward and accuracy matters for the patient's ongoing care. During one trauma case with significant blood loss, staying organized with the counting and timing meant the surgical team always knew exactly where we stood without having to ask. In these fast, high-pressure situations, I find that being the steady point of accurate information is often as valuable as any single task I perform.
How do you manage a pediatric respiratory distress case where the child's condition is rapidly declining?
With children, I move fast but try to keep my voice calm, since a frightened child breathes worse, and a calm nurse helps calm the parents too. I quickly assess work of breathing, looking for nasal flaring, grunting, chest retractions, and skin color, and I get oxygen saturation and respiratory rate straight away. I position the child in whatever way helps them breathe easiest, often upright on a parent's lap, since forcing a child to lie down can worsen distress. I call for senior help early rather than waiting to see if the child improves, because deterioration in children can happen very quickly. I prepare age-appropriate equipment in advance, since using adult-sized gear wastes critical time. I keep the parents close and briefly informed, because a child in an unfamiliar environment does better with a trusted adult present, and calm parents help keep the child calmer. In one case, a toddler with worsening bronchiolitis was escalated to high-flow oxygen and a pediatric review within minutes of arrival because I acted on early warning signs rather than waiting. With children, my rule is always to escalate early rather than watch and wait.
How do you handle a situation where a critical medication dose ordered during a code seems incorrect?
Even in the middle of a code, I speak up immediately if a dose looks wrong, because a medication error during resuscitation can cause serious harm on top of the original emergency. I state clearly and specifically what I believe the correct dose should be, referencing the protocol or weight-based calculation rather than just saying I am unsure. I ask for quick confirmation, usually from the team leader or a second clinician, before administering it, since a few seconds to double-check is almost always worth it. There was a code where an adrenaline dose called out seemed higher than the standard adult dose, and voicing that immediately led to a quick correction before it was given. I try to raise these concerns without creating panic in the room, using a firm but calm tone so the team stays focused. Afterward, I always follow up with proper documentation and, if needed, an incident report, not to assign blame, but so the system can be reviewed. I believe a culture where anyone can question a dose without fear of being shut down is one of the most important safety features any resuscitation team can have.
What is your protocol when caring for a stroke patient who falls just inside the window for thrombolytics?
Time becomes the priority the moment stroke is suspected, so I act quickly but carefully rather than rushing carelessly. I confirm the last known well time precisely, asking family members directly if the patient cannot tell me, since this single detail decides whether treatment is even an option. I get the patient to imaging as fast as possible, alerting the stroke team and radiology in advance so nothing is delayed on arrival. While this is happening, I complete a focused neurological assessment, obtain 4 access, check blood glucose, and gather a quick medication and allergy history, since these details affect whether thrombolytics can be given safely. I stay closely involved in the decision-making conversation with the doctor, making sure results come back quickly and are acted on without delay. Once treatment is given, I monitor very closely for any signs of bleeding or neurological change, checking vitals and neurostatus frequently in the following hours. In a case where the window was tight, having glucose for access and history ready before the scan even returned meant treatment started within minutes of the decision. In stroke care, every process I run in parallel rather than in sequence saves brain tissue.
Describe a time you experienced a significant communication breakdown with a physician during a critical procedure. How was it resolved?
During a difficult intubation, I called out a dropping oxygen saturation, but in the noise of the room, the doctor did not hear me the first time, and the team kept proceeding a little longer than I was comfortable with. Rather than repeating quietly and hoping, I stepped closer, said the doctor's name directly, and stated the number clearly, which got immediate attention and led to a pause and repositioning before continuing safely. Afterwards, once the patient was stable, I raised the moment briefly with the doctor, not to blame anyone, but to agree on a clearer way to flag urgent numbers during procedures, such as always stating a number twice if there is no response. We agreed on that approach going forward, and it made later procedures we did together noticeably smoother. That experience taught me that communication breakdowns and high-stress moments are rarely about disrespect. They are usually about noise, focus, and habit, and they are best resolved by naming the moment honestly afterwards rather than letting it become an unspoken tension. Now I try to build in that kind of clear call-out language before high-risk procedures even begin.
How do you balance speed and accuracy when performing handoff reports during a rapid shift change or ICU transfer?
I rely on a consistent structure so speed does not come at the cost of missing something important. I use a standard format, covering diagnosis, current concerns, recent changes, pending results, and any task still outstanding, so I am not trying to remember the order under pressure. I prioritize the information that affects immediate safety first, such as unstable vitals or medications due soon, before moving to background details that can wait. I also give the receiving nurse a chance to ask questions before I leave, rather than talking at them and rushing off, because a rushed handoff often creates more work later when something gets missed. During a particularly busy night with several ICU transfers happening close together, sticking to this same structure each time meant I did not lose track of details even as the pace increased. I also write brief supporting notes rather than relying purely on memory, especially for numbers like drain output or drug doses. Speed and accuracy are not really opposites to me. A clear structure lets me move quickly precisely because I am not second-guessing what I might have forgotten.
Tell me about a time you made a clinical error or near miss in a fast-paced environment. How did you handle it?
Early in a busy shift, I nearly gave a medication to the wrong patient after being interrupted mid-task and picking up where I thought I had left off. I caught it during my final identity check, using the patient's wristband and asking them to state their name, which is a habit I never skip regardless of how rushed I feel. Even though the error did not reach the patient, I still reported it as a near miss through our incident system, because I believe these reports mattered just as much as ones where harm occurred. I spoke honestly with my supervisor about what led to the interruption and near miss, and we discussed ways to reduce interruptions during medication preparation, like using a do not disturb indicator. I did not try to minimize or hide what happened, since I know that culture of openness is what actually keeps patients safe. Since then, I am even stricter about completing one task fully before starting another, even under pressure. I see moments like this as proof that safety checks exist precisely because busy, well-meaning staff can still make mistakes, and the system needs to catch what a rushed moment might miss.
How do you manage your own stress and avoid burnout after a shift involving a tragic or traumatic outcome?
After a particularly hard shift, such as one where a young patient did not survive despite the whole team's efforts, I try not to pretend I am unaffected. I usually take a few quiet minutes before driving home, sometimes just sitting in my car, rather than moving straight from that intensity into normal life. I talked to a trusted colleague who was there, since debriefing with someone who understands the situation helps more than explaining it to someone outside healthcare. Our unit also runs informal debriefs after major incidents, and I make a point of attending, because staying silent tends to let stress build up quietly over time. Outside of work, I keep a few non-negotiable habits, like regular exercise and proper sleep, which I protect even when I am tired, because they are what actually keep me steady long-term. I also try to notice in myself when I am becoming more irritable or detached than usual, since that is often an early sign I need support rather than just pushing through. I see managing this as part of my professional responsibility, not a personal weakness, because a burnt-out nurse cannot give patients the care they deserve.
How do you handle a scenario where a colleague is consistently failing to complete their assigned tasks, putting patient safety at risk?
I address it directly with the colleague first, privately, and without accusation, since there is often a reason behind the pattern, such as being overwhelmed or struggling with something outside work. I once noticed a colleague repeatedly missing routine observations on their patients during a busy rotation, so I asked her directly, away from other staff, how she was managing her workload. It turned out she was struggling with a new area of the ward and felt embarrassed to ask for help. I offered to run through the routine with her a few times, and the missed task stopped. If a direct conversation like that does not resolve the issue, or if the risk to patients is immediate, I do not stay silent out of loyalty. I escalate it to the charge nurse or manager because patient safety has to come before personal comfort. I always try to frame these conversations around support rather than blame, since most staff want to do their job well and simply need help or accountability. I have learned that raising concerns early and kindly usually prevents small gaps from becoming serious incidents later.